Welcome to Dr. Joe Unplugged. The topics discussed in this podcast will reflect my opinions and are not in any way to be regarded as medical advice. Today I'm delighted to be joined by Luke Slawomirski. Luke, welcome to the program.
Thanks for inviting me.
Now, I've invited you on. I read a piece that you wrote on LinkedIn, Medical Authority as Moral Authority, the Prescience of the Magic Mountain. And I was really drawn to this. I'm not familiar with that book, and it was written 100 years ago. And yet it appears to have, as you say, prescient, captured the issues that we face today in terms of the medicalisation of life, which is an issue that I've had an interest in, that we just broaden the parameters of what we class as pathology, mental health or physical health. We lower thresholds, and so it goes. So this is maybe not as new a concept as I probably thought, was really fascinating. And you've written about it really, really well. So I encourage listeners to go on and read the whole piece. But before we get into the conversation, Luke, tell us a little bit about yourself.
Yeah, well, thanks, Joe. Thanks for having me on, and thanks for the kind words. So I'm a health economist. I work in health policy. I've worked at the OECD in Paris. I've also worked for the state government, federal government. I have a clinical background, though, so I started out as a physio, and I worked in hospitals, in private practice here and overseas. And but about 10 years into my career, I started becoming very interested in how the system functioned, and I could definitely start to see some problems and inefficiencies there. And so I decided to did some postgrad study and moved into the policy space, and here I am thinking about these issues, these bigger picture issues like over-medicalization and appropriation of authority and those sorts of things. So it's prompted me to pen a few things. I read the book about several years ago now, and what prompted me to write the piece was actually reading about perfectly healthy people getting full body MRI scans and paying for it out of their own pocket, of course, but that to me just seems absolutely insane because it's expensive. It's about $3,000. And without symptoms, you're bound to pick up something that's sort of not quite what you'd expect. But 99% of the time, these things are just incidental. But once they're picked up, obviously that causes anxiety and stress, and it sets in train a medical pathway, which is not only costly for the person, it's also costly for the taxpayer and anyone who holds a private health insurance policy because it's reflected in the premiums. So I do feel that the medical space is encroaching into normal life, and I do think that the medical professions are trying to take more and more of a slice of our autonomy and existence, and not just the profession, but also by pharmaceutical companies and the whole industry associated with medicine, which is a very lucrative one.
The whole body MRIs, I think, are getting more popular here, not as much. I mean, I assume trend has come from America, as most
every
of these,
trend
as these things do. Yeah. And look, you're right. Well, what are called Incidentalomas. So we found a little spot. Probably may well have been there all your life, but it's not been seen before because it's never been scanned. A bit like in different ways when we do X-rays, or not X-rays, sorry, scans of the low back. Somebody's got back pain. You find a slightly disc bulge. Probably been there all the time, but it immediately gets the blame for the current pain.
Exactly.
But to your point before about medicine going further, I mean, we probably saw the zenith of that perhaps in the early part of this decade when policy didn't just incorporate medical advice. You had politicians saying, we're following the medical advice. Well, that sort of, they weren't. So basically they were taking their orders from a small group of doctors. I mean, it might have been the peak of all of that.
Yeah, I think the influence of the medical professions, but also the whole industry that surrounds it, pathology and tests, and obviously the medical device industry and pharmaceutical industry. It's one ecosystem that kind of thrives when the classification of diseases expanded. Obviously, they have more influence and they make more money. And I think the influence has grown to a point where now, like you say, people who are trained in medical practice are making very far-reaching policy decisions and decisions that govern how our money's allocated. And our behaviour is steered. So, and look, sometimes I think sometimes the advice is right. With smoking, for example, we all know, even though there's never actually been a randomised controlled trial, we have a wealth of observational evidence that tells us, without a shadow of a doubt, that smoking causes a range of problems. And I think the initiatives to lower smoking rates, especially among young people, although now they've all gone to vaping, has been a really great public health initiative in Australia. And I think it's been shown to generate billions in savings and also productivity. But there's other examples where it simply just doesn't make sense to classify people in terms of whether they fall in or out of a certain pathology, because that puts a label on people. It affects their behaviour. It then affects their productivity. I think this is most resonant at the moment with neurodevelopmental disorders, spectrum disorder and ADHD.
Well, that is something I think Rob, RFK Jr., and again, he's not everybody's cup of tea, but it doesn't mean that everything he says isn't right, observed the number of children in America with these diagnoses versus when he was at school in the 1960s. Now, you wouldn't think in 1 or 2 generations there's been that much genetic change that suddenly there's a massive increase in this problem. Now, I accept some of it could be better recognition, but you got to think some of it is relabeling. But beyond that, broadening of how it gets defined. So the bigger, the broader the category. So, for example, with ADHD, the number of criteria that you need has gone down. The length of time you need to have it for it's gone down. Pretty much everybody could get that diagnosis without too much ado.
I absolutely agree, and I think you've hit the nail on the head there. It's totally about that. Probably 80% of it is related to these expanding criteria, and I think with RFK Jr., yes, I think what they say, even a broken clock is right twice a day. It's a case of that. What he said about autism and those diagnoses are probably spot on. I don't think his attribution to some of the causes are that accurate. So Tylenol, for example, paracetamol, and I also, he's doing a lot of things that are not good in my view. But this pointing out to people that you are actually in control of your health. And although there's a lot of commercial and social determinants of health which will steer people's behaviour, people from deprived backgrounds are more likely to eat junk food because it's cheaper, or they haven't been role modelled good eating habits or smoking, whatever. But at the end of the day, it's choices, and we have to remember that
people have agency.
Or agency and autonomy. And I think that's part of the themes in the book, how that agency is taken away from the main protagonist, and in fact all the people that are in the sanatorium where the book's set. It's taken away by the doctors who have an interest in keeping people there as long as possible and sort of labelling them with a diagnosis.
Well, that's a really good segue. We sort of started in the middle. So, can you tell us a brief? And I'm hoping you read it. You said it a few years ago. So I'm assuming it's still in print or it's accessible.
Oh, it's a classic. Yeah,
okay.
It's one of the it's in the German literature canon. I read it in German because, as I said to you earlier, I grew up in Austria, so I'm fluent in German.
There's an English
only just
version.
Oh yeah. There's many different translations, and I think I actually think the book should be required reading for medical trainees.
Okay.
Yeah.
So can you give us a brief précis on the book? 'Cause I think that will give some context to to all the listeners?
Yeah, so it's set in the early 20th century, in the interwar period, so between World War I and II. And the main protagonist is a chap from Hamburg who his name is Hans, and he goes to a sanatorium in Davos, in the Swiss Alps, to visit his cousin who's there being treated for tuberculosis. And Hans is sort of portrayed as a bit of a naive character who's sort of easily impressed, and sort of the type of guy who is the most powerful person is the last person he spoke to, kind of thing. So easily influenced, but sort of curious about life and sort of learning. It's what the Germans call a Bildungsroman, which is a novel about growth and development. So a classic sort of classic novel, if you like. So he arrives at the sanatorium, and he starts to meet all these different characters, and the very persuasive chief doctor there, whose name is Behrens. And very soon he starts to adopt some of the symptoms that some of the other patients have, a cough and fever, and soon enough he has an X-ray. Of course, he's persuaded to have an X-ray, and he's institutionalized. So it's never made clear in the book whether actually he does have tuberculosis. But
potential social contagion.
Well, that's right, and I think the book is. Well, I don't think the book's about that. I think the book's more about it's the sanatorium as a microcosm of European society at the time.
Okay. So you got different characters in the sanatorium.
You have various different characters. You have his cousin, obviously, who ends up dying. But you have various characters who represent different ideologies. So you have a humanist, Settembrini. You have a communist, so called NAFTA, who sort of represents the more authoritarian ideologies. You have a guy called Peppercorn, who is sort of full of vitality and life, sort of live every day as if it was your last. You have the love interest, Madame Chauchat, who sort of leads Hans along and makes him realize various things about himself. I mean, the book is so rich. You can interpret it in about 10 different ways, like all good novels. And it's very, very long as well. I should warn people. But Hans ends up, he was meant to go for 6 weeks, and he ends up staying for 7 years in the sanatorium.
Okay.
7 years.
So
he's fully institutionalized. And the book's really good at playing with time. So 5 weeks can go by, and it seems like a minute.
So he's arrived as a visitor.
Yeah.
Like, I'll just come and see, like you go to a hospital or, home. Yeah, nice to see you, and you leave.
Right.
But he gets admitted.
That's right.
Okay.
That's right. He ends up getting admitted. So it's sort of a metaphor for the modern day medical system. Sooner or later, everyone's a patient because we always have a back pain or something wrong with us, and we're appropriated into the system. And he, during his time there, he learns a lot about himself. He learns a lot about life, and he eventually is. The war starts. Second World War starts, and he goes to fight, and it's sort of implied that he dies fighting. So, kind of a sad ending. But it struck me early on, Behrens, the head physician, says, you belong here. That's very clear. You belong here. I've seen that from the start. And then, well, let's just see how you develop, and let's do the scan. And slowly, there's a real social economy in the place where people live by their diagnoses. There's sort of social capital involved in having a label, a pathological label applied to them. And so I think he sort of buys into that, and he's persuaded to become one of them. And 7 years later, he's off to fight the war, and he dies, which is a bit of a downer, but learns a lot in the meantime, at least.
All right. So he does end up leaving the sanatorium.
He does, yes.
Officially cured, in inverted commas?
No, it's never made clear.
Oh,
and
no,
I think
you
that's
said
the whole
whether
point.
he does or doesn't.
Yeah, it's because his symptoms are vague, and he's there, because I think he just sort of enjoys the different people knocking around, and he obviously has his love interest who leaves and comes back. And it sort of becomes a way of life for him. And for me, it just really, some of the dialogue and the subtext became very clear to me that Mann, the author Thomas Mann, is, if not deliberately, then certainly it comes across as a prototype of a very medicalized society, particularly in terms of how much authority the doctors have over not just the clinical aspect of the patients' lives or the visitors' lives, but in terms of everything that they do. So their clinical authority kind of morphs into a moral and ethical authority. So it dictates how these patients conduct their lives. And it's sort of, that reflects to me how the medical profession and other industry groups have taken over the sort of high level decisions that are made about our healthcare system and our health system.
Is that in part because it's a bit of a vacuum and human beings by nature need some sort of organisation in society and something that they regard as maybe not higher than themselves, but somebody to say this is the way we do things around here and this is how we structure what we do, that people look to that, and if there's no guiding philosophy or system, then that's a vacuum and nature abhors a vacuum.
I think that's right. And I think particularly in health, because there's such an epistemic distance between the experts and ordinary people, that it's easy to relinquish your control to someone, and that control then can easily bleed into other aspects, not just the clinical. So I think as a society, there is, I don't know if it's because other forms of authority have receded, or because, you know, I mean, the counterpoint to what you're saying is perhaps the vaccine skepticism. You know, we're seeing a massive reaction now against expertise when it comes to vaccination and immunisation. And this is, again, stemming from the US, but we're really seeing it here. There's an AMA report that came out recently that says vaccination rates are coming down, and it's a problem. So, but I definitely think that there is some sort of some exploitation of the knowledge gap, and I think that's probably the vacuum you're talking about. And so the medical expertise is now become a proxy for other forms of expertise, which is sort of more in the moral and philosophical domains, and how we should allocate our resources, our scarce resources, our money to what things. And of course, the medical profession will always steer that towards intervention rather than prevention.
Yeah, and I mean, to your previous point, there is also that wonderful thing known as Overreach, which is, I think the vast majority of people were quite happy to say, I don't want myself or my child to get, measles or polio or, diphtheria, which we don't see a lot of these days. But when they were told and pretty much forced to get a vaccine, which they were told would stop them getting COVID and would stop them passing it on, and then demonstrably it did neither of that. I think it's not entirely unreasonable that some people are saying, well, if you pretty much lied to me about this, what else might you be lying to me about? I think that the medical profession has to own, rather than just blithely blame misinformation and disinformation and point fingers. I think there's some degree of needing to admit, well, we thought it was a good idea at the time, but, people have, and that gets back to agency. I mean, what are your thoughts on the own goal that perhaps has been kicked?
I think, Joe, that's an excellent point, a really good insight. But there's two aspects to this, really. I think, yes, COVID definitely changed things because of how rapidly things were developed, and there was quite a bit of panic. Communication wasn't great. Let's not forget, it's 45 years, I think, this week that smallpox was eradicated. That was declared by the World Health Organization. massive win for humanity. But yes, so with the COVID vaccine, I think you're absolutely right. But I think there's an element of hoisted by your own petard with the medical profession, because we're constantly sort of bombarded with information that, medical technology now can solve everything, apart from curing cancer, perhaps. Although we're getting there, I think, with some of the new CAR T and CRISPR technology. But, we can solve anything. So you just have to trust us. And then, as you said, COVID vaccine didn't stop people getting COVID. It might have, it probably reduced the severity of the symptoms and your likelihood of dying from COVID, and also your likelihood of transmitting it.
Probably in an older age group.
Yeah. But, it sort of goes against that idea of vaccination being, you just won't get it. And I think that was a real mistake. And I think that came down to poor communication and perhaps poor implementation. But you've got to give the policymakers a bit of credit for, a bit of, not credit, but give them a bit of leeway, because things were happening so fast and people were dying and ICUs were overflowing. When you make decisions under pressure, you often make the wrong decision. I still think rolling out the vaccine was better than not rolling it out, but I think the communication around it and the way it was done could have been a lot better by policymakers and also by the medical professions. Yeah, I absolutely agree.
Jay Bhattacharya, who's now the head of the, actually get it right, I think he's the head of the NIH, or basically Fauci's job.
Yeah.
I mean, he in second half of 2020 said, yes, we can deal with COVID. We'll get back to the main point. We sort of got a bit of a sidetrack. The Great Barrington Declaration said, yes, we need to have focused protection. There are certain people who are at increased risk of COVID and of dying of COVID,
yes,
and there are people who are at very negligible risk.
Yes.
And all the data, even by that stage, was showing that people under the age of 65 without, even 75, without a whole host of other medical conditions were at negligible risk of serious illness. Yeah. And I think that was known. And Bhattacharya was shadow banned and now he's got Fauci's job. But there's another line here that you've got, which I thought was really interesting. The clinical gaze turns bodies into objects of interpretation and management. It positions the individual not as an agent, but as a body to be monitored, measured, and classified. And I haven't thought myself, earlier on you said that people used to go to the doctor for some episodic illness. You had a chest infection, or you cut yourself, or maybe you needed your appendix out. So it was very, very much, and that's what the medical system has historically been built on, is episodic care. But now we have chronic illnesses, and I'm not convinced that our current system, particularly with tertiary hospitals, does chronic illness particularly well. We give people lots of tablets, but I don't know if we really, and that's useful, I'm not saying it isn't, but we don't really do chronic disease as well as we do acute disease.
No, we don't. And I think you're spot on that the system isn't designed for modern health needs. So it's a system designed for the last century. And we're having a hard time reorienting it. We tend to let people fall sick and then treat them in expensive tertiary places. And I wrote about this. I had something published last week. We have an illness system, not a health system.
Absolutely.
And I think that's partly a legacy of how it used to be, as you said. But it's also, again, that kind of professional dominance and overreach that a tertiary system is one that suits providers, especially acute specialists. Yeah. And I think, we started with that line from the piece about bodies being, humans stop being humans but become bodies for observation and classification. That I wrote that because it does, like, when you look at how specialists operate, they just look at the body part.
Yeah,
they don't look at the whole person. And I've seen this in my own work in hospitals and in the private sector, and I've seen this with family members who have a health problem that's multi-organic
Yes.
and multifaceted, and a lot of it's cognitive. But the specialist will just focus on the body part that they're specializing in. And so I think that we miss a lot by hyper-specializing and having such an acute focused system. We not only not catch disease early when it's there, of course not. This kind of goes against what we're saying about over-diagnosis and expanding definitions. But, someone who has diabetes, let's not let it get to them needing lower limb surgery.
Yeah.
Let's help them manage it early. And I think having a back-laden system like we do avoids that. And also we need to give people more agency to manage their own health.
I think
stay healthy rather than...
Yeah. I mean, the concept of preventative medicine is we'll catch it early, and that's good. But I think there's a step before that, which is not getting it in the first
primary
place.
Prevention, yeah.
And that's like particularly with type 2 diabetes, with high blood pressure, and other, I suppose related into that to some degree, heart disease. Rates of type 2 diabetes were way, way lower than they are now in the up to about the 1970s and early 80s, and regular listeners to the podcast will know my view on the low-fat dietary guidelines.
Yes.
But that's not even so much preventing illness, that's actually keeping people healthy. And your point about us having an illness or disease system rather than a health system always strikes me that the measure of the health system is how many hospital beds we open. And maybe it's me, but I would see, and I'd really like your view on this, a health system that needs more hospital beds by definition is not doing its job because it's not keeping people healthy. I could be wrong. I'm happy to hear otherwise.
Look, I'm in furious agreement with you. And I think, it's important to make the fundamental point that health and illness are not two sides of the same coin. Health isn't the absence of disease. It's a lot more than that. And that's what you first need to really understand. People really need to understand that. It's a lot more than just not having health problems. But, we're absolutely terrible at measuring success. And, but a health minister will always prefer to talk about how many hospital beds there are, or cut the ribbon at an urgent care clinic, than announce a program that's going to help disadvantaged kids eat better meals, at school, because it's not sexy, unfortunately.
Look, I think politicians love going to openings. Like they can cut the ribbon. We've got a building. That's nice. But I think the other problem we've got, and look, we don't want to have governments in power for long periods of time. You've got to turf them out quite regularly. But any money invested in, if you like, prevention is not going to show any benefit in the forward estimates. It's way beyond the forward estimates. But even then, it's that whole thinking that says that government has to spend money. And I think there's a role for government money. But it also implies, well, I can't be healthy unless the government runs a program. And I think that, again, what do you see about that in terms of what that says to people about their own agency to make their own decisions?
No, I think that's right. You've highlighted another important point, that it's where we've ended up. I think people expect the government or other institutions to do the heavy lifting for them. I'm not really sure why. I'm not really sure how we can reverse that. I think investing more in education, like actual schooling, it would be a great way to improve people's literacy and health literacy, because the two are definitely linked. And also, you mentioned the government, but we are now seeing, which is good, that private health insurers are moving more and more into prevention, and that's because they don't want people going to hospital because it costs them money and it pushes up premiums. So they have skin in the game in keeping people healthy, financial skin in the game. Whereas other actors in the healthcare system have more financial benefit from people getting sick and then getting expensive treatments.
Oh, look, there's absolutely more money in treating illness than in people being healthy. And your point about private health insurers, it fascinates me that every time private health insurers want to do anything in a community setting, the AMA in particular will scream blue murder, and they trot out this line, which I know for a fact because I was there at the time. I'm not going to give any names or any drill. This term that gets thrown around, US-style managed care, is a completely made-up term. It has no meaning, but it sounds, we don't want to be like the US. We can't do it. So you're right. But there are players who
follow the money. But your point about the US style managed care, well, the paradox is that we are actually starting to resemble the US because we're so focused on acute downstream intervention, which is exactly the same as the US. So we're now spending more and more of our GDP on healthcare, and our expenditure on acute services is growing faster than our expenditure on primary care. And we're becoming like the US, but just not in the way the AMA is trying to frame it in terms of the vertical integration.
The USA spends, 17, 18% of GDP on its nominally its health system, and the US GDP is way bigger than anybody else's. That's 80% above OECD, and you'll know this better than me. OECD average. Well, I don't think they live 80% longer.
No, they live not as long, and they have terrible outcomes. Look, wherever you look, infant mortality rates in Louisiana, in some parts of Louisiana, are worse than sub-Saharan Africa, and they're about 70%. The OECD average is 9.3%. Of GDP.
So nearly double.
We're at 10.3%, and it's creeping up because we're so acute focused. And they have virtually no investment in prevention or primary care. It's all laden into hospitals and specialists as well. And we're starting to look like that more and more, unfortunately.
Japan has apparently an obesity rate of about 4%. And there was a program, I think Nick Coatsworth did, it was earlier in the year. He went to Japan amongst other places, and they really spoke to the children at a young age about healthy eating, and they sort of encouraged that through the schools, which gets back to your point about education. Are there lessons for us from Japan? They've got a long life expectancy. I mean, obviously there's some cultural differences.
Yes.
But how much exercise you do, how much and what you eat, I'm not sure that's absolutely, we can say, well, the Japanese get it and nobody else can.
I think, Japan's a unique case. It's a different culture, and, it has a very different history. Obviously, the country was basically remodeled after the war, a new constitution. And I think that's when their life expectancy started to shoot up, actually. So before the war, it wasn't much different to the rest of the world.
Right.
But after the war, for some reason, so it's not diet, because I don't think the diet changed much. For some reason, they started living longer. But the point about longevity is not really how long you live; it's how much of those years you spend in good health.
Yes.
And getting back to Australia, our gap between our healthy lifespan and our total lifespan is currently at 12 years. And
12 years.
12 years. That's 14% of our life expectancy at 83. Now, guess where that puts us in the world rankings?
I suspect not in a good place, is my guess.
Second.
Behind the USA.
Behind the USA. Right?
Hey.
Yeah. So, and what does that tell us about our health system? Well, it tells us we don't have a health system. We have an illness system that lets people get sick, and then we blast them with expensive stuff. So if someone has a stroke or a heart attack, our survival rates are really good. They're really low, which is good. Yes. They're among the best in the world. But our avoidable hospitalizations for things like diabetes, asthma, things that should be treated in the community, are 30% above the OECD average. And the Institute of Health and Welfare estimates the cost to be $7.7 billion a year, which is roughly what we spend on the private health insurance rebate.
Okay.
So avoidable people going to hospital that should really not need to, that should be managed in the community. So yeah.
Are governments aware of this and there's nothing that they can do, or they're not aware of it, or they're aware of it and, dare I say, they just actually don't care because it'll be somebody else's problem after so many years?
I think all of those are true. I think there's a lot of complacency that's crept in. As you said before, the political cycle is short, especially at federal level, 3 years. The ministers will want to be seen to be doing something. Like the bulk billing incentive, for example, my own view is that it's useless. There's
Completely agree.
I just think I actually don't believe the data on the bulk billing rates. I think they're far lower than we're told. I think there's something fishy going on with how those data are generated. So Butler, all his predecessors, both parties are just not interested. And I think it's also when someone does try to address the fundamental issues, the lobby, like the AMA, will come out swinging. They'll put the stethoscopes around their neck and come out in front of the cameras and say stuff like, your granny's going to miss out on getting her cataracts done if this reform goes through. And so they're, polys are rightly anxious because doctors have built up, maybe not so much pharmaceutical companies, but the medical profession has built up this image of benevolence, like we are just here for the population health benefit, and we are not self-interested at all. Well, that's nonsense. I mean, they're just human. They're human. Like, well, you're a doctor. Everyone. We all have part of us is interested in the social good, but part of us is interested in our own selfish interests. So to expect that from anyone is unreasonable.
I think also...
So politicians are nervous to take on the fundamental structural issues that we're facing.
Oh, it reminds me, and people can find this online, there's a brilliant video by this guy, Remy, from the USA. It was done years and years and years ago, and every proposal that puts up, he says, you just want people to die. And that sort of shuts down everything.
Death panels.
Look, I think in the medical profession, I obviously can speak as a doctor, there's a degree of believing your own publicity. So I genuinely believe most of my colleagues, they're not malintended. They're not trying to rip anybody off. They just genuinely believe their own publicity. And it's groupthink. And again, I think we saw that in the early part of the decade. There was groupthink rather than a contest of ideas.
And COVID as well, to an extent, like what you were saying before. And I think you said before we started recording, when you have a hammer, everything's a nail. And I think there's an element of that. And look, it's very hard, as you know, it's very hard to become a doctor. It's arduous. It's hard. It's a lot of study and a lot of dedication. But it's natural then that you start seeing the world through a certain prism, and we need to be cognizant of that when we talk about policy making and then the trade-offs that inevitably need to be made. There's only so much money we can spend on health and healthcare.
We still need roads. We need schools.
That's right.
There's a lot of other things we need.
Every operation that happens in a hospital is something that doesn't happen upstream. Several things that don't happen upstream because operations are expensive.
We could talk for hours, and in fact, Luke, I'd be really keen to get you back for a further discussion. But before I wrap up, I'd like to read the last paragraph from this piece. That's the author of the Magic Mountains. Man's physicians govern the sanatorium. Today's professions govern the system. Whether this is desirable is a question we must ask. But first, we must recognise that this is happening. Maybe just expand a little bit on that, whether we've got blind spots. And then to wrap up, if you've got a few, maybe takeaway key thoughts for the listeners.
Yeah, so the main point I was trying to make with the piece was that we can't let expertise in a narrow area become expertise in how we live our lives and how we set policy. So clinical authority shouldn't become moral authority. And I think it's important for people to remember that the health system belongs to us, to you, me, Arne, as citizens, as taxpayers, because we fund it through tax, through our private health insurance.
And our own pocket.
And increasingly out of our own pocket. That's right. So we should be the ones who decide about the high-level priorities, the principles on which it should be based, the way resources are allocated and for what, and also what things aren't funded, some of the trade-offs. That's really up to us. It shouldn't be up to people who have a direct stake in what the arrangements are. And I think that's the first step to really change some of the issues that we've covered today, which have been broad, but I think it all comes back to that, that we should be the ones to decide how the system is built and structured and on what principles and priorities, because it's ours and it's not theirs.
Are you a glass half full or a glass half empty sort of guy when it comes to maybe the next 10, 20 years or so?
Oh, look, I think we're going to have there's a reckoning coming because we're just going to run out of money.
Yep.
So I think sooner or later, I mean, we're drifting in the direction of the US. I think Australians are more street smart, and we're going to have more people asking questions. People like me and hopefully others start to ask questions about is this really the best way we could be spending our scarce resources and our money on this system, or is there another way better? So I think there is hope. Of course, like everything, it'll happen very slowly, but
and
eventually it will happen.
Yeah, and I think that's a great endpoint, Luke. Asking questions. I think collectively we need to ask more questions. I think there's a lot of evidence that shows that when we don't ask questions, we all just go along. Questions can change directions and force, in some respects, answers. Luke Slawomirski, it's been an absolute pleasure to have you on the podcast today. Thank you so much for your time, and we'll get you back in the not too distant future.
Thanks very much, Joe. It's been great.
Thanks for listening to Dr. Joe Unplugged. If you enjoyed this podcast, please like, share, and consider subscribing. Tell your friends. If there are topics you'd like to see covered, be in touch through the chat or email info@drjoe.net.au. We'll be uploading new content each Monday, and soon we'll be putting these videos out on X. You can follow me there at Dr. Joe's DIY Health.